Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Hello, everyone. I am Corey Grant. I'm an assistant professor at the University of Tennessee, and I'm faculty in the Tennessee Population Health Consortium and the Tennessee Heart Health Network. I want to welcome everyone to our presentation today that's entitled Bridging the Gap, Demystifying Virtual Care for Better Patient Outcomes. We're honored to have with us here today Dr. Stephen Gubin, who is a cardiologist and president of the Stern Cardiovascular Clinic in Memphis, and Scott Laster, who is co-founder and CEO of MyCarePath, a Memphis-based company that specializes in remote patient monitoring, chronic care management, and health assessments. And they are going to talk about the clinical and financial benefits of remote patient monitoring for blood pressure control, with some examples that support virtual care as a viable and essential intervention to promote patient-centered care. I'll be monitoring the chat for the presentation today, so please let us know who you are and your role in your organization, and feel free to put your questions into the chat during the presentation. And with that, I will turn it over to our presenters.
Thank you so much, Corey. Thank you, UT and the Population Health Network. We are very excited today to go through this. I've got Dr. Gubin with me. He's always working clinically, so he's blessed us with some time in between procedures. He's going to go through a brief background of Stern so that you've got a flair for how big the group is, and then their experience so far leveraging virtual care in their practice.
Thank you, Scott. I'm honored to be here and to speak to you. I'm the president of the Stern Cardiovascular Foundation. We've been in practice for 103 years. Our founding partner, Dr. Newton Stern, brought the first EKG machine to Memphis. So we've always been interested in looking at new technology and ways to help our patients. And I would say 3 years ago, when we started our relationship with MyCare and working with Scott, we've had a very positive experience with MyCare, and I think we've helped a lot of our patients. As everybody knows, that hypertension is one of the modifiable risk factors that we use, that we always want to try to control in our patients to decrease the risk of cardiovascular issues. And a lot of patients, when they come in the office, their blood pressure is elevated, and they always say, well, my blood pressure is well controlled at home. So we've always been interested in doing some outpatient blood pressure monitoring. And I'm from Missouri, so I always want, the patient, they say, you have to show me that your blood pressure is well controlled. And so rather than having patients just take your blood pressure and keep a diary, we've found that MyCare this company has been very, very helpful in the treatment of our patients. They take home this really good blood pressure monitor, and we usually tell the patients to check their blood pressure in the morning and the evening. And when they check their blood pressure with the MyCare device, it automatically comes to our office. So it's real time. When they take their blood pressure, the patient sees their reading, and at the same time, we can see their readings. So usually when the patients come back, we will show them a graph of their blood pressure. And it's been very, very helpful. We found a lot of patients that thought that their blood pressure was under control. It really wasn't. And the patients seem to really like it. And one of the things that I've found very, very helpful with this company, when patients check their blood pressure on their own, and if it's high or if it's low, no one knows about it until they show their doctor. But since we're getting these readings real time, MyCare is always monitoring these readings, and they have a nurse that works with them. They provide the nurse, and if a patient gets an abnormal reading, high or low, they will call the patient immediately. And our patients have found this very comforting. It's been very, very helpful. If they get extremely high reading, they may tell the patient they need to go to the emergency room. We also have a protocol, so they know they can, tell the patient, give them hints on what they can do. or when they need to call the office, when they need to go to the ER, or when they need to get their medications adjusted. Also, which has been very helpful, if the patient doesn't check their blood pressure on a regular basis, the nurse will also call the patient and say, we haven't gotten any readings from you in the last 3 or 4 days. So that's been very helpful. And as you will know, the guidelines now want the ideal blood pressure is like 120/80. We used to be happy with like maybe 140 less than 90, but now the guidelines have gotten more stringent, and our group is really trying hard patients to goal. And with the use of the MyCare, we think that we're really helping our patients. We feel like their blood pressure is under better control, and that we're really helping our patients. And as you well know, the number one cause of death in both men and women is heart disease. And one of the real modifiable risk factors to decrease to make the numbers better is blood pressure. And with the help of MyCare, we have really helped a lot of patients, a lot of doctors. We have 46 doctors in our group, and many nurse practitioners. And not all of us are using MyCare yet, but we're rolling it out, and more of the doctors are starting to use MyCare and finding it very helpful for their patients. And the MyCare company has been extremely easy to work with and always available. Whenever we have any issues or we have some suggestions to make the MyCare better, we just call Scott and he's on it right away. And so it's been a very positive relationship. And we look forward to continuing to work with them very closely and to help more patients.
Thank you, Dr. Goop. I've got a few slides that go through the history and some of the transitions that I can step through for us. And then I know you've got to get back to procedures, so you feel free to bounce whenever you need to. So to chronicle some of the background of what your practice has been through, in January of 2023, we did a pilot launch of the program and partnered with MyCare. It was only on the technology side because at first the group wanted to keep the clinical services in-house and have each of the specific physician pods manage the outreach to the patients with the initial elements. And what we found was it became a little bit onerous just for the makeup within private practice groups because they're so busy with the struggle of day-to-day and keeping up with the volume of patients that are coming in. But still, through that pilot, we had about 2% of your overall physician group that were referring patients into the program for blood pressure management. Then in July of 2023, we agreed to shift some of those clinical services for the initial, just the remote monitoring piece out to let MyCare support some of those components. And so we deployed our team to perform all the services from enrollment to monitoring. So if you don't mind, could you describe like when you see a patient that has a condition that might be good for remote monitoring, how you walk them through it, and then you just designate it to your MA, and then he or she passes it over to the company?
Right. So whenever we decide a patient needs a home blood pressure monitoring, all of the nurses that I work with have been educated on how to give this device to our patient. So we actually, while they're in the office, we give them their blood pressure monitor. We teach them how to use it. We teach them how to communicate if they have any issues. So they get to monitor right when they're there, and right away they can start sending the readings to our group, and which is also monitored by MyCare. So it's very simple.
Thank you. And then the MA just sends us a list at the end of the day of which those patients were. Our team does the enrollment and then reaches out to the patient to introduce them to their care coordinator. And so since that process got streamlined, now we've gone from about 2% to 16% of the physicians in the group that are referring patients into the program, just because of the ease of being able to manage that component. And since we've been able to do that as well, there's been roughly a 30% patient increase and revenue increase as a service line kind of month over month. And then today we're continuing to expand, just as Dr. Gubin described, with introductions to new physician pods within the broader group. They're obviously quite a large group, and so there's a lot of different people to be introduced to over periods of time. Here's a great study that shows with some of their patients and another group that MyCare supports out in California, some initial blood pressure scores. We took a retrospective cohort, of almost 1,100 patients, took almost 250,000 readings from those patients, and we showed over a 3-month time frame a very quick reduction in systolic and diastolic, and then controlled state of those patients over an appropriate period of time of 3 months. And then that actually persisted beyond from the data that we've seen beneath the lower confidence line. So I think obviously the remote monitoring program is not driving these metrics, but hopefully it's helping patients be more persistent with their therapy over periods of time. Have you seen that from your patients?
Very much so. And I mean, every time a patient comes back and I show them the readings, I'd say 95% plus love this monitoring. They feel secure. They love the fact that if there's something or their numbers are off and they're too high or too low, someone calls them. So it gives them a lot of comfort.
That's a great point. I think sometimes just because you see so many patients and you make yourself so accessible, it's hard to believe that patients don't have as much access to care as you would think that they would have. But hopefully this becomes an extension of how you do practice with your patient, how you provide care, make it just a little bit more accessible for that peace of mind. And like any good service line, needs to be financially feasible for the group as well. And so these are some of the numbers from the group that they've shared with us of actual collections. The light blue represents the time when they were doing the monitoring, and the navy blue represents when the monitoring and enrollment services were transitioned over to the company. And it just shows a nice growth clip. And now they're pushing 6 digits in regards to monthly recurring revenues with the patient group, which is tremendous because they're providing an extension of care and a new type of service that today we feel patients are excited for. But in the future, if you think about it, how so many things are consumerized, we feel patients will start to demand these types of solutions just so they can stay connected to their specialty providers and primary care groups for the ones managing these types of conditions like hypertension and others. These are some, if you don't mind, I don't even know if you've seen this, but these are some feedback from your patients inside the group. So James T has a daughter in Houston who's helping her manage the program. So we have a mobile app that they can actually see what their parents' readings are. But the father is a patient in Memphis. And now they're both at ease due to the care management and blood pressure data provided. So she said, my father and I are extremely pleased with my care's care and services. She has 5 stars in our book, who's their monitor. This was a wonderful and simple experience. Thank you. Then we have Tamika, who recently diagnosed with hypertension, described her rapid peace of mind from connectivity and symptoms through control. This one's a little bit more complicated, but it was a great. I absolutely love our monitor. I felt so connected to my cardiologist. The My Care coordinator is knowledgeable, patient, and so cheerful, making me feel even more secure during my time of extreme symptoms. Feedback resulted in doctors sending me a new prescription immediately, and my high blood pressure dropped significantly by bedtime, and I had normal blood pressure the next day with no headaches or dizziness. Love this technology in my monitor. So she was obviously very verbose about her experience, which was tremendous. And I won't read all of them, but they're all basically in line with this. And this is what it's all about, is about good clinical care. We call our company Health Digital, not digital health. That needs to be able to generate revenue to be a persistent service line in modern healthcare, but providing good care for these patients is what it's all about.
And one other thing that's really been helpful to us in cardiology, you get a lot of data. We have pacemakers, defibrillators. I mean, there's always data coming into the office, and sometimes we're overwhelmed. And by partnering with My Care, by them providing a nurse that can overlook all these readings from our patients, it's really helped our group a lot because we know the patients are being well taken care of. We don't have to worry about patients being missed because we're overwhelmed. They're helping us out. And if someone really gets a critical reading, they can just call us. So that's really been a good relationship, and they helped our patients and also helped the group.
That's tremendous. Well, thank you for the time, Dr. Gubin. We really appreciate it.
Thank you all for having me.
Hope you have a good rest of the day.
Thanks. If they have questions, they can call me.
Oh, perfect. Dr. Gubin just said if you have questions, we'll make sure that his contact info is included so that you could follow up with him as well. Thank you all for letting him squeeze that in the middle of procedures. So now I'll take over on this section and we'll go through some of the components of the actual mechanics of virtual care as a service line, is what we really call it. And sometimes people get uncomfortable on talking about the finances of the clinical piece of care, but I think it's an important component. Any sort of a service line that you do, if it's a diagnostics service line, an actual care delivery service line, any of those service lines provide good clinical care and provide revenue on the back end. And we've got a special guest speaker, we hope, and Bill Green, that'll be coming up to provide more of an administrator and practice perspective on that end. The CEO of a management services group that really used to be just in the greater Memphis Mid-South area, but now is expanding up into Michigan and some other spaces as well. He'll give more of the operational business side of how they've operationalized it. But hopefully, as we step through this, this will be meaningful information too. So again, we call it virtual care navigation, but as a service line for your practices. And again, I actually come from an orthopedics background, not clinically, but from a professional setting. And if I hurt myself and went into a local orthopedic shop, that shop first is going to send me through to get an x-ray. And then from the x-ray standpoint, I'm going to get a physical exam. And then after that, there's going to be some sort of a treatment regimen, durable medical equipment or injections, or maybe surgical treatment or physical therapy. Each of those are different service lines. And so all we've done as a business is try to cast a meaningfully broad net and find the different reimbursement codes that exist that allow either provisions of distanced, so not physically face to face, either synchronous or asynchronous, meaning it happens at the same time or happens at a separate time, types of clinical care delivery to be an extension of medical practices. And so some examples of mechanics that help us achieve that are needing physical connected devices. The best use case that we've talked about here, because of the focus on hypertension within the Tennessee PopNet Consortium and the Tennessee Healthy Heart Initiative, are blood pressure monitors. But we have a handful of other devices that are relevant as well. Weight scales to gauge fluid retention for congestive heart failure, or glucometers for diabetes, et cetera. There's a host of different devices that make sense. We've got about 5 other more novel devices in the pipeline that are not just more over-the-counter vitals capture. Not everyone in this market, but we have a mobile app and SMS text-based platform. So we can actually engage patients fairly automatedly from that and ensure that they're not just getting a monitor and kind of left in a black hole. They actually get patient education, and they have the ability to communicate back and forth in modalities that they're comfortable with. So that helps the patient feel reinforced and hopefully gives them the confidence to have the peace of mind to keep going. The whole platform is based on behavioral change elements that I won't unpack on this call, but they're important for persistence with platforms like this. The data from either the connected devices or the mobile app, which also has symptom checks and other types of patient-reported outcome surveys that are clinically validated instruments, just like a device reading. We have over 350 of those built into the platform. So all of those different data readings come in through an intelligence layer into the enterprise cloud system. So as Dr. Gubin described, we worked with he and then some of the other quality managers within their group to come up with consistent triaging and alerting measures. And so that's the intelligence filter that we put the data through to make sure that we're not looking at false positives, false negatives. We're attending to the data that needs to be attended to. And then our organization ultimately provides the outreach as a first step if it's needed. We'll actually have 2 different views. For Stern Cardiovascular here in Memphis, we provide all the clinical services that are needed, from patient enrollment through ongoing monitoring and management to escalation, and then going back to the patient feedback and actually closing the loop with the patient. For other groups like Honeycomb, we actually just provide the technology because they built the infrastructure of clinical services and triaging and those elements. So we have a scaled solution to help you meet where you are for your service line. But we do also provide the services piece. So what's the value of virtual care as a service line? Hopefully these things are pretty intuitive post-COVID, but the elements that we think are relevant are, from a patient's vantage, better connection and guidance. I mentioned this earlier, but I think sometimes it's easy to forget because as a care provider, you're providing a lot of care, a lot of hours of the day. And if you feel like you're giving yourself for your patients, it's definitely that way. But the inundating volume of what they call the silver tsunami of a lot of patients coming into this market are creating a pressure test on your time and how much you can give for those patients. So actually having this as almost a concierge care extension of your practice is a meaningful extension just because of access, and making sure that a patient feels comfortable in the comfort of their home to be able to reach out and do that gives them that peace of mind and confidence to reach out so that they can get even some of the more mundane questions answered and not having to then bog down your staff when that happens. If we're providing the clinical services, we can help answer a lot of the FAQs that come up as a part of normal clinical care, normal cycles of care. And again, we deliver care in the way that you want it done, when you want it done, and how you want it done. So we're following your cue of what you would like us to answer or what you would like us to escalate into your practice to make sure that we're not taking any liberties you don't want taken. And then thirdly, it improves clinical outcomes. It's probably intuitive, but proactive care is better clinical care. And so it helps reduce downstream clinical issues by catching problems before they become more costly and more complex. And then lastly, it increases revenue as any service line does. Again, we cast that meaningfully broad net of all the different reimbursement codes. So whether it be the more well-known, but maybe somewhat mystified remote physiologic monitoring, RPM, or remote therapeutic monitoring, RTM, or care management services like chronic or principal care management, or health assessments like annual wellness visits or brief behavioral assessments. All those different types of things are things that we wrap around care pathways and deliver them where you want them delivered and where it makes sense. But just like where Stern is using us all in with clinical services, Honeycomb is only using us for the technology. We only apply these clinical services where you want them done, so we can scale them up or down as you see fit. So I just touched on all these different elements, and I'll flash them up now and then say we can provide the clinical services as well. So when you're building a service line, this might just be my impression, but most medical groups have most of their service lines well ingrained for now decades of time. So building a service line is not necessarily a muscle that's been exercised inside these groups in the recent 10-ish years. So that's why we aim to be the easy button for this. We come with the consulting efforts at no cost to help stand these up because we've done it for 40-ish practices coast to coast to date. So it's not easy work to stand it up, but we're there as a part of that, almost like a free McKinsey to help do that. And then again, plug these different boxes in where you see fit and where you see help from it. Just a brief background of our company's scalability. Like I said, 40 some odd different organizations, as small as a single physician group up to as large as the 12th largest health organization with Advent Health, based out of Orlando, Florida, but in 9 different states. So we've scaled within large health systems and we've scaled within small groups. I think that's, again, where we call ourselves health digital, not digital health. Most of our organization has healthcare backgrounds, whether it be through device, pharmaceuticals, or actual clinical care delivery to patients. We've collected over 162 million patient points over the course of our existence over the past 5 years young age. And we've partnered across 22 different states. We've got all the greens fees that are needed in this market. So FDA registered, reimbursed across the different payers that you see there. We are a patented solution that has been published. It's not patent pending for how we provide care and some of the graphical representations that exist that Dr. Gubin referenced. 14 trademarks, and we're HIPAA and SOC 2 Type 2 compliant on the tech stack that we're built on, with over 10 billion interactions to date, not just device readings measured. So it's a scalable system, and you shouldn't be scared of anything breaking on that end. And really, in its simplest form for hypertension, for those that are experienced with this in primary care settings or in specialty settings, you're very familiar with the view on the left. This kind of sheet that you ask the patient to fill out, and the patients are familiar with this, kind of a little medical hub in their home that they try to set up with a cuff and a way to write it down so that they can bring it back to the office. But what that yields is kind of splotchy interactions. So whether it's every other week or whether it's 3 months, if they're a little bit more rural and they don't have access to your clinic, those are the lines of sight that you see for these tabulated views or table views of their blood pressure readings. And you don't have much context around it. Were they stressed out that day? What happened that day? You could ask them for the high blood pressure readings, but like any normal human nature, I've just forgotten what I did this morning before we got on this call. So things are hard to contextualize. Where on the right-hand side, you can see these automated readings coming through cellular-enabled devices like Dr. Gubin was describing, where within 5 to 10 minutes, we can get the reading. If it's a reading that passes some threshold of high or low, we then have a staff reach out and contextualize that. How have you been doing? Have there been other elements? Have you been taking your medication appropriately? Is this still the medication that you're taking? So we can help really get the right context around the device reading, and then follow the programmatic protocol that's put in place to say, should that reading really be escalated, or should a patient take their medication, go take another reading within a fixed number of hours, and then get back and see if it's good or bad. So we really help filter out the false positives, false negatives, and get real readings to be managed. So that's really hopefully a meaningful overview of just our organization specifically, where we've been as a business, and then focusing in a little bit on the clinical value of hypertension. And we are doing this and have this opportunity because we've got the preferred partnership with the University of Tennessee Health Science College. So we've been a vetted organization through that initiative. So hopefully we come with a little bit more credibility on that end, but we're, I believe, the only one at this point that meets that requirement. So hopefully that's helpful and why we're on the call and going through this. Another point that we thought was meaningful and why we said demystify virtual care, just in some of the early days in the Tennessee PopNet Consortium and some of these other views, we've run into some groups and practices that are said either A, I've tried it and XYZ happened, or I've heard a horror story of someone else doing something like this and something bad happened from a billing perspective or a patient experience. And no program is perfect, but these are the things that we've learned. And even if it's not my care path, we hope you could suss out other organizations with some of these don'ts and do's lists. So if you run into a group and they're signing up patients via mass list uploads without the patient's consent, and honestly without your consent, because you might have given them access to the EMR, but they go in and do their own runs of data listings and do outreaches proactively without your blessing. That's definitely a no-no. We've actually heard of people doing this inside of groups within Tennessee and these organizations. So we'll work with the clinical team to ensure patient consent and education. Every one of our onboarding phone calls is recorded for quality purposes. And we'll either do this via one by one, by each patient on a prospective basis, or we'll run an aligned campaign, meaning which clinical conditions make sense, which are the insurance companies you'd like to go after, and then what's the script that you want us to do when introducing this. It's my care on behalf of XY organization calling with this provider's blessing. Those types of things to really help patients understand what this is. Second kind of don't is billing the clients, i.e. your physician groups, even when the patients are not using the services or in some instances have actually passed away or died. We've heard, again, those are some of the horror stories of other organizations doing those different types of things. What we do is there's a per CPT code reimbursement structure that our company follows. So if there's a patient on the platform that's not engaged with the program, we work with you to work the patient off the program in a way that makes sense. And our internal auditing team reviews the billing each cycle for accuracy to make sure that it's only patients that have utilized the system is what you would be billed for. Therefore, it's all that you can reimburse for. So it's a profitable service line, day one, patient one. The third bullet, charging upfront costs for devices and app access, making enrollment risky and expensive. So that's again something I touched on earlier of service lines being a risky thing, and it's not necessarily a muscle that's been flexed in a while. So we try to take the financial teeth and risk out of it. So from that perspective, we're transparent. We build the cost of the devices into each per patient per month component for this. And we're transparent with everything before the billing and contracting of a new client and those elements. So again, we try to take and actually absorb a lot of the risk of building a new service line as an organization. Some groups only offer piecemeal health assessments or RPM or RTM or CCM or PCM. They're not a full suite of virtual care. So we end up with these different point solutions, and it gets point solution fatigue. Go to this dashboard to look at these things for the staff or this other one for other elements. So we offer the full virtual suite, and then we can do the services for you so you're not siloed with those elements. But again, we can launch in any way that you want. So we can scale it up to be everything or scale it down just to be one service. And you could do that service, and we're just the technology. Another watch out is not providing service or any device support once the patient is enrolled. So we've heard horror stories of this too, where they enroll a bunch of patients on a list and they don't necessarily do their due diligence to send outreach to those patients. So patients call up to the office and say, what's this bill for? With our group, we've got protocolized driven elements and again, recorded calls to make sure that we're meeting the requirements for the CPT codes for the purposes of audit support, et cetera, but also just good clinical care, making sure we're, again, doing care the way that you want it as an extension of your practice. So that's the full support and app outreach and automated support, as well as the manual support that we do. Then the other component that we don't do is we've got protocolized views of how frequently to reach out to patients so they don't view it as incessant nagging. So we have thresholds of doing these things over different periods of time and all those different components. And we've just pressure tested that. So in some months it's it'll be 3 calls. In some months it might just be 1 call outreach to the patient. And then after a certain element of a patient's non-engagement, we'll remove them from the system because it's not appropriate to bill you, or it's not appropriate for you to be billed for that. So we work to make sure that there's not those kind of dead spaces of patients. Again, we want this to be a viable service line that's providing clinical value and care for those patients on an extended basis. So with that, hopefully this was short and sweet, but meaningful as it relates to the word of a customer from Dr. Gubin's vantage, as well as an overview of our background as a business on this end. So thank you for the time on this piece. And I don't see if Bill has had a chance to join. In fairness to him, it was a last minute ask on our end for him to be able to hop on. But if he is, great. If not, then I'll pass it over back to Corey and the UT team.
Thank you. That was great. Does anybody have questions? And do I need to? Well, I guess I'll get us started with questions. I'm sorry if you covered this, but how accurate are the blood pressure readings from home? And do you do anything to ensure that they are accurate?
That's a great question. Thank you for that. We've got the specification sheet. I'll pull up the exact elements from it, but from the blood pressure monitors, it's interesting. I'll butcher the numbers if I tried to actually say exactly what they were, but I know that there's over thousands of different blood pressure monitor brands that exist in the market. We only use blood pressure monitors that have been FDA cleared and also passed a different level of scrutiny called Validated, or validatebp.org is the name of the organization that does that. So they take it a level beyond. Typical FDA clearance involves repeatability and reproducibility, but up to the level of just a historical benchmark. And so that gives you some elements of confidence of the device and products, and that's a requirement for the reimbursement in the market, is to have an FDA clear device. But a lot of companies don't go to that next level of validation. And so that's one of the things that we ensure with the blood pressure monitors that we do. Not a lot, that organization doesn't exist in every single device world, but it does, thankfully, in the blood pressure management world, and we ensure that they have that.
Great.
And if a patient does have, and funny enough, there is a bit of puts and takes, maybe a different just clinical use case of a response to that question. We've had an organization, I remember a nephrology group out in California, and they had a patient that was told that they had white coat hypertension because it was only high during the clinical visits. But then when they went home and used their over-the-counter blood pressure monitor, it seemed more in line with regular blood pressure ranges. And they got our monitor, and then they said, this can't be right because it's consistently reading higher than what my blood pressure monitor at home did. And so we brought both cuffs up to the office and compared it to the cuff at the office, and found that the monitor that we utilize was more accurate. And so we were actually able to help that patient realize they didn't just have in-office or white coat hypertension, but rather did have kind of a low-grade hypertension on an ongoing outpatient basis. So they were able to put them on some sort of a therapeutic and manage it. So we do run into triaging of, is this monitor more accurate than the other one if a patient's already on something like that? But that's another great use case of our clinical services that help kind of navigate some of that so that it's not a burden operationally on the staff as they launch these types of programs.
That's great. We do have a question in the chat from Jennifer Campbell. Is there extra cost to the patient for enrolling in RPM services? Great question.
It's another great question. Today, there are copay obligations for patients associated with it. What we find is oftentimes Medicare with a supplement covers a lot of the patient's obligation and costs on those ends. So that's a great initial patient population to go after. Other patients, because it's positioned ultimately as concierge care, we originally, funny enough, built this business before the reimbursement codes existed in RPM. So we built it around and stepped away from our comfortable jobs because we believed in the thought that patients would be willing to come out of pocket for some of these fees. And we found that that's true. I don't know the numbers specifically in our program overall, but a healthy minority of our patients are on commercial payers or have a copay obligation and continue to pay for it. There's big ranges because it depends on plan to plan of what it is that they do. It is a part of our consenting process of a patient, whether it's through an outreach campaign where we do one-off calls to hundreds of patients, but also if we manage that patient on a prospective basis, we ensure that we review with them, you have this type of an insurance. If we do have past experience with it, we'll reference to them and say, this insurance typically costs between this and this range. If we don't have that data, we'll just say it is a risk of those elements. Would you like to consent to be a part of the program still? And they can opt yes or no as a part of it. And we've learned in the early days, truthfully, we kind of tiptoed around it with our patient scripts. And we found that didn't service anyone well. Then a patient would get on, maybe get frustrated with the program because of an expense associated with it. So we're very plain with it. And sometimes if that happens outside of the office, it's better because then the patient has had time to calm down. They're not anxious about what's going on in the clinical setting, and they can truly have a thoughtful approach to the program in general, both clinically and do they have the time to dedicate to it, as well as to the clinical the financial obligation to it.
And then a follow-up question. Does 10 care cover RPM?
Ooh, I am not close enough to the day in, day out to know every single payer that pays, but I will take that as an action to follow up with that maybe we could send back around specifically to the question asker, but then also to the group. Apologies. I should know that.
Hey, Scott.
Hey, Ricky.
Hey, so to answer that, so there has been work that's been done at the state level. It depends at times, as you may know, there's a collaborative group of whether it's AmeriGroup, Blue Care, or United Healthcare, depending on who covers that 10 care patient, and the reimbursable payment of what they're calling as telehealth services, which can be included as CCM and RPM for some of their patients that are enrolled. It's a one-off group situation, though, Scott, as you mentioned, though, depending on the actual group that's covering that 10 care patient.
Oh, perfect. Thank you. Oh, and Annie's supporting with the correct. And that brings up, thank you, Annie. And that brings up another great question around there were some of the groups that we socialized with early on for federally qualified health centers or rural health clinics, the FQHCs or RHCs. In the early days, virtual care was really just chronic care management. And so they had I believe it was G0511 was the CPT code, but it was only for chronic care management. In 2024, they actually expanded the use of that G code, they being CMS and the Medicare Physician Fee Schedule, for use for remote physiologic monitoring as well, and therapeutic monitoring. And because there was only one CPT code, you used it for every billable instance. And so the G0511 would be billed for the CPT code to enroll a patient, 99453. It would be used for the CPT code for the 16 device readings, 99454. You'd bill G0511 again. And then for the 20 minutes of monitoring of a patient, 99457, you would use that same G code. It was a stark adjustment or change and made the financials even more advantageous in that market than it was in other markets. But what we've heard for the 2025 proposed Medicare Physician Fee Schedule is that they went from no access to extreme access. They're taking a baby step back, and they're just going to use the framework that they had already built. So they're actually using all of the CPT codes for RPM, RTM, CCM, PCM, et cetera, but they will still be accessible for FQHCs and RHCs. Obviously, it's a proposed schedule, so it's not approved yet, but that's what we hear is coming in 2025, which makes logical sense. But the good news is FQHCs and RHCs do have access to these reimbursements as well, not just CCM or chronic care management, but also for the different remote patient monitoring elements of physiologic and therapeutic this year and moving forward, which is great. And I think it's further bolstering the support and showing the trends that Medicare and Medicaid feel that this is here to stay. They view this as a proactive, ultimately downstream cost avoidant solution. And as any payer is oftentimes, whether it be at state, federal, or private levels, it's a balancing act. So if they add new reimbursement in other areas, they're redacting back in other programs. So again, for providing these services, it isn't bad to be able to go get financial advantage for doing it because you're being redacted back in other spaces. I'm sure you feel the pain over the last 5 years, the reduction in payments and those types of things. So it's because they're making way for these types of asynchronous virtual care, proactive care elements that all will hope will help not create more cost, but rather stem the tide of the downstream expenses years down the road.
Hey, Scott, one final point on the TennCare and Blue Care and the coverage for Medicaid patients and recipients. One of the things that you mentioned during your presentation that's so very important, under all the payer requirements, it has to be FDA approved device. And I don't know, you were going very quickly, I understand, but I mean, also that's a very important thing that's called out, that it can't just be a normalized device. That has to be offered something that is FDA approved, which, as he mentioned during the process, the technology and platforms MyCarePath has available is approved through the FDA. So I wanted to bring that up, Scott.
So, oh, I see Bill just joined us, but I have one more quick question, and maybe this will connect the two. I don't know, but I'm interested in knowing how somebody, like, what's the first step if somebody's interested in getting started? And then maybe you and Bill can answer that together.
Sure. It all starts on our end with you've got the standard obligatory license agreements and those components, but we actually have a program that we've trademarked and called HyperPath. And it starts with an assessment. We have forms and processes that we use in our company that just goes through a list of a simple questionnaire. So we go through a list of a guided set of questions to make sure that we have all the documents in place on our side to kick off an orientation and education. Then over the coming week or 2 weeks, depending on the level of aggressiveness that the organization wants to launch a program, we go through and we'll do a provider orientation and cover the elements from the provider's vantage of how to prescribe this to a patient. What are some pearls and helpful elements from that piece? Then to the care team's perspective, which is a little bit more in depth. It's a lot more in depth if they're doing the clinical services themselves, because we'll actually go through an education process of how to use the dashboards and do the documentation. If we're doing the clinical services, it's a light touch element on that piece. And then the third component is going through the revenue cycle or the billing team and stepping through those points. So first step, orientation. Second, third, and fourth steps are trainings around the provider team, the care team, and the billing team to make sure that everybody knows how to manage it. And then we typically have a heavy hand of involvement. We might be there on site for the first week or two of launch, depending on the size of the organization and their level of comfort and comfortability, or confidence and comfortability. And then after that, then we send the horse out, because hopefully the horse has been able to drink instead of leading it to water. And then everyone has good success. And then each account has a customer success manager on an ongoing basis. It's their point of contact, as Dr. Gubin referenced. It's a quick reach out if there's any question on an ongoing basis. Thank you all for the questions.
Can't get myself off of mute. Okay, well, that's great. Do you want to introduce Bill?
That'd be wonderful. Bill, thank you for joining.
Oh, I'm sorry I'm late. I'm very sorry.
No, it's worked out wonderfully. Thank you. So Bill Breen's the CEO of an organization known as Honeycomb. They're a multifaceted organization, but they supply the services for primary care organizations and specialty care organizations. As I referenced, they began here in Memphis, where we're based, Memphis, Tennessee, but they've now spread their wings beyond the greater Mid-South and are in different states like Michigan and others along the way. So they're growing rapidly. As we referenced at the beginning of the call, MyCare can be an end-to-end and do all the clinical services and everything, or we can be fractionalized and turned into just what's needed. So Bill has been a wonderful partner to MyCarePath, and we, in essence, quote unquote, just provide the technology for he and his team to support their vision for supporting organizations like your organizations. So he has a storied experience from hospital systems and physician practice management here in Memphis with the Methodist group, and then has now built his own organization. I'm probably not doing you justice, Bill, but thanks for being on the call. Pass it over to you now.
No, you're doing a great job. Can you all hear me okay?
You sound great.
Okay, great. Yeah, so no, you overdid it there. I don't deserve that introduction, but a couple of things. I'm not just trying to be self-congratulatory to MyCare, but what I really like about working with MyCare is the flexibility that we have to partner in various ways. Like what's going to make it work, and how do we get there together? And I think that level of ingenuity, innovation, and sort of like flexibility is just, it's a breath of fresh air. For us, we see ourselves as first and foremost serving our own patients, but I feel like a missionary for Scott a little bit because I believe in the platform. I believe there's an opportunity, and we certainly at Honeycomb believe there's an opportunity to take the platform and add some of our health coaching to it, and that's exactly what we've done with several outside clients, non-Honeycomb clients, you might say. But I'm super bullish on RPM as a methodology to take control over downstream costs and the need to coordinate care better, especially in the primary care environment, but also in the cardiology environment and several other areas. So from what I would echo about what Scott said is, from the outset, the implementation plan can be, it depends on what you're going to do with the platform and what role MyCare is going to play. But we were super impressed with the ability not only to train but to retrain, because you're going to have staff turnover. You're going to have the need to obviously, as the platform itself might have modifications to retrain. They've been wonderful to work with. For us, we've begun to one facet, I guess I would say, is that yes, you can use the MyCare platform and RPM as a one-size-fits-all for people who qualify for it. That works. I mean, if they qualify and you want to create greater connectivity with the patient in between visits, it's wonderful to do. It's the whole reason that Medicare decided to invest in this new benefit. But more importantly than that, getting your high-cost patients on RPM is a real opportunity, because the data is replete out there. The studies show this connectivity helps reduce downstream costs. It does so even more so when somebody's expensive. So we're beginning to really, only now, but we should have done it a year ago, really ask ourselves why we haven't targeted our high cost patients. We've sort of had a shotgun approach, which is okay, but we also need a concurrent laser beam approach toward people, as an example, that might be on a shared savings plan, and we might pick the 100 out of the 1,000 that are the most expensive and target those. So the platform is wonderful. It's flexible, and we're very, very grateful that we're able to use this technology.
Thank you, Bill. Anyone have
Absolutely.
questions? Sorry.
I had a random question actually, because Bill, I was always impressed with how you thought about virtual care inside of your
Yep.
organization at an operational level. The clinical utility of it, with going in the theme of kind of demystifying it, it seems like this. Dr. Gubin referenced it at the beginning of the call that cardiologists are a little bit more comfortable, I think, with these asynchronous data-driven things because they get so much data, but demystifying it as being kind of this fancy thing that just spits out tons of data, and then also like actual usefulness of it. Do you mind trying to speak to that from your vantage with what you've done with your organization, of where you've applied it and why you've applied it in those ways?
Yeah, and I may disappoint you with my answer. I hope I don't. But I think Dr. Gubin's absolutely right. I mean, I think in the cardiac space, being really data driven in between visits has always sort of been there with Holter monitors and other opportunities or needs, to understand the patient's environment when they're not in the office. I think for primary care, it's a fairly new phenomenon to have that, right? So I'm very sensitive to the fact that primary care providers and their support staff already feel like there's 1,000 more things for them to worry about today than there were 10 years ago. So honestly, I sort of question whether, and this is where I may be disappointing, I think there are some people that the way to demystify it is to say, when do you want us to intervene in contacting you? And if your favored way of involvement is for us to contact you when we see there's a problem that you help define the limits to, we'll do it that way rather than you have to us to expect you to look at the data points every single day, if I'm making sense. So if I'm working with a provider and I'm trying to ease them into this, it could very well be that I say, tell me where your limits are, and we'll document that. And if it's 3 measurements in a row above X or Y, then we'll engage with you. Then the role we would then play is sort of is to be that early warning system for them, rather than force them to go look at the data every day, or necessarily even when the patient shows up, only. So I think it's better to sometimes step them into this world more slowly, but that may mean that Nectar or Honeycomb takes some role of being that filter, you know, that human filter that says, oh, something that was just said or some measurement just set off an alarm, and I'm going to call Dr. Katz and talk to him about this. Does that make sense, Scott?
That makes great sense.
And so I don't think one size fits all with every provider. I think the platform gives us the ability to play whatever role. If the provider wants to be highly involved in looking at data points every day, more power to them. If they don't, that doesn't mean we don't sell them RPM. It just means maybe in between we fill some void of review that they don't feel ready to do on their own.
Well, I have a question. Have you had to hire additional personnel to assist in that interim to review the data?
No, I mean, when the methodology is for us to sit in that void, we've sort of just factored it in. So, you know, we're using some arithmetic right now that just assumes that for some portion of it, the provider is not going to go look at the data, and we're going to have to be the one to alert them to it. And I'm okay with that. I mean, I'd rather go that route. I could get on my high horse about it, but that doesn't really get me anywhere. The real benefit I'm after is intervention, right? And it's knowledge about a patient's condition that I otherwise wouldn't have had. And so as long as I act on it, I could choose to act on it indirectly by providing the data to the provider and expecting them to do it. But on the back end, maybe I'm being a bit of a control freak. I like knowing what's going on and actually like the responsibility, because then I can act in between the health coach and the MA or the MP or MD. I can actually act on it, document it, and document what we did for the patient based on that data. And I like that. But to answer your question directly, no, I have not had to. I've sort of incorporated that into the health coach role.
Thank you. Thank you. I just wanted to get the audience to know whether that was
sure.
something that you had to do. Thank you.
You're welcome.
Another one, in the spirit of being through frequent question and answer sessions and things planned, but you referenced, Bill, when you were going through the initial piece, that from a primary care vantage, there are so many new things that have to be documented, captured, and measured, etc., that there's definitely a fatigue there. As a part of those, all the acronyms of quality, the MIPS and MACRA and high star and all those different ratings. Have you used this as a way to try to help automate any of those components yet?
Absolutely. That's a very good question. So let me give you a perfect example. One of the problems with blood pressure measurement in the office is always going to be placement of the patient's level of anxiety, et cetera, right? So you learn early on, I'm not clinical, but I've been around enough to hear this 100 times. You take the blood pressure again, right? If it looks high, and maybe you do it anyway, you take it 2 or 3 times, let the patient settle down, white coat, hypertension goes down. But let's say I see this quite often. Well, I don't say quite often. I must make myself sound like we've got issues, but I see it sometimes. So patient comes in, they've got they evidence high blood pressure, but they're not on medication, and they obviously could exhibit the symptoms of hypertension, but they're controlled most of the time. My example would be that if I can't get them back in to check their blood pressure again, I can use the measurements, CAN. I can use the measurements from the platform to document their blood pressure is under control before the end of the year. So these data points, in the case of primary care, can be utilized to close gaps. So I think that's an example of, my goal is to try to see patients with chronic disease 3 to 4 times a year, a minimum of 3. I really like 4, and get their AWV done. Okay, if I can do that, the data shows that more to the point of about the 5th visit, every visit saves cost in peer-reviewed data. After the 5th visit, it doesn't do it anymore. Then it adds cost. But if I can't get them in for that 4th visit, what benefits us is the information provided in between visits, which is where RPM comes in. And whether it be a pulse ox or a scale, or it be the blood pressure monitoring device, it gives us insight into the patient condition that we can document in the chart. And then many times that's very useful for closing gaps.
That's great. Thank you.
You're welcome.
Any other questions for either Scott or Bill? I have a question for you, Scott. Do you have any published research or clinical studies that you can share, case studies?
We have one scientific exhibit that was presented at ACR on the patient persistence on the platform that I can send through afterwards.
Okay.
That data set that Dr. Gubin shared from some of the blood pressure readings, that's something with a little bit larger data set that we're aspiring to get published. We're just trying to find the right partners to help us do that, since that's not necessarily in our repertoire.
Great, thank you. All right, I guess if we don't have any additional questions, we can give everyone back 5 minutes. But thank you again. This was a great presentation, and we really appreciate your time.
Thank you for the opportunity. Thanks, everyone.
Thank you.
Thank you.
Take care.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee, and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.